Good morning, everyone. Thank you so much for joining us. On behalf of Integrity Continuing Education, I am thrilled to be a part of this 2023 Nurse Practitioner Summit. So thank you so much. We don't take it for granted that you've gotten up on your Saturday morning. Hopefully you have your coffee and that you're going to spend the next few hours getting some continuing education, great continuing education. I've already heard it. And so such good information. And so I'll be excited to kind of walk you through that. But first, of course, we always have housekeeping. So let's walk through that. I am Brett Snodgrass. I am a nurse practitioner. I am currently the Palliative Medicine Operations Director for Baptist Health Systems in Memphis, Tennessee, an award-winning blogger. More than anything, I'm a nurse practitioner at heart. So thrilled to spend the day with you and really talk through where we've been, where we're going, and just some great education. I will be your program monitor and your keynote speaker today. So I'll tell you a little bit more about what I do in my practice as we move forward. Of course, a provider statement, you're getting continuing education provided by Integrity Continuing Education and through Global Education Group. So this is all the information you'll need, but at the end of this presentation, you'll be evaluating it, you'll be doing some questions throughout, and then you will be provided your continuing education for the day that we all need. Our program supporters are here, Actelion Pharmaceuticals, GRAIL LLC, and Merck Sharp Dohme. And our educational partners, a very, very special thank you to our educational partners, Florida Nurse Practitioner Network, Maryland Academy of Advanced Practice Clinicians, the Nurse Practitioner Association of New York State, and Pennsylvania Coalition of Nurse Practitioners. I've been honored to speak at quite a few of your conventions and your conferences. So I know many of you, so I hope you're here today. But what great groups to be partnering with us in this educational continuing education. So how do you get your continuing education? That is always very important. First, you're going to view the program content, participate in real-time polling questions. Throughout, you're going to see that there's polling questions, and then you're going to complete the evaluation form at the end. A link to that evaluation form will be provided at the top of your screen and will also be provided at the end of the program. And finally, you'll get the certificate processed and emailed to you within 4 weeks after you've completed your evaluation form. You must do all of this to get your continuing education, so don't miss a step, but we'll remind you how to do that toward the end. And then these are for viewers. So mind you, that was for those viewing this live on our website. For viewers on social media, so you can find us on social media and it will be live there. If you're viewing on social media, you'll have the option of joining us live, just as we've talked about. But you can view us through social media. You'll view the program content. You'll complete the pre-test, post-test, and evaluation forms. And these are links will be posted on Facebook, Twitter, and LinkedIn. So many opportunities, and you too will get your certificate processed and emailed in about 4 weeks after you've completed your assessment test and your evaluation form. So you have options. Okay, you're going to get some polling questions, and this is going to be a webcast, real-time, pre-test, post-test polling questions. You want to answer the polling questions, just click on the button that contains your preferred response. Again, social media viewers, this will not be available to you in real time, but you will be sent links to the pre-test and post-test questions that you must complete. And if you're viewing on social media and wish to join our interactive webcast and be a part of the real-time polling, please go to this website right here. That's in front of you. All right, let's get to it. Let's audience polling questions. Here we go. Which of the following most closely describes your practice? Is it hospital network, institutional settings such as skilled nursing, corrections, mental hospitals and psychiatric units, retail pharmacies, urgent care, private practice, group practice? man. All right. The top is hospital networks. Institutional came next, urgent care. Let's see. Let's scroll through. Well, I'm attempting to. Let's see. Oh,
Yeah, you might need to scroll down. I'm sorry to see
it's
that.
not letting me scroll down.
Okay. Yeah, it looks like we have a nice arrangement.
Nice arrangement of different areas of practice setting. Perfect. And I'm sorry, I can't see the bottom of it. All right. What is your professional specialty? Primary care, family practice, acute care, adult, geriatric, long-term, cardiology, oncology, hematology, pulmonology, respiratory, or other. And if other, please answer in the chat box. Primary care, family practice, and acute care take the lead, of course. So very commonly. So thank you so much for answering. This is what those questions will look like. So it kind of got you into it, and so you kind of know what it's going to look like. So let's jump in without further ado. I know that I stand between the rest of your Saturday. So we want to provide great education, but we also don't want to take too much of your time. So we are going to jog through this today. I'm going to be presenting the keynote, Nurse Practitioners, Past, Present, Future, Staying Relevant and Resilient. I have not talked for years, I never mentioned a lot about relevancy, resiliency, but man, over the last few years, we can think about what has happened and what has gone on. It's been really in the forefront of my mind. And so I'm really excited to talk with you about it. And I think it's vitally important as providers that we stay not only relevant, more than anything, resilient, because we need you and we need you doing what you're doing. So keep in mind, that's what we're going to be talking about. I'm Brett Snodgrass. I recently completed my doctorate of nursing practice from University of Alabama, Huntsville. And so it took me, I've been a nurse for 26 years, and I have been a nurse practitioner for 16 years. And it took me just a few years ago to finally go back and get that DNP. And I'm very proud that I have it, and I feel honored. And I really feel it stretched me as a provider in different ways, but really made me think differently. And it really made me think into a macro environment of healthcare. So I'm thrilled to be doing that. I am Palliative Medicine Operations Director for Baptist Health Systems in Memphis, Tennessee. We service 24 hospitals. We just bought our 24th hospital. And our goal is to have some type of palliative presence within all of our hospital systems, really working to help patients with chronic life-limiting illness. Not only that, but more than anything, to also support providers. We know in these hospital systems, this can be very difficult to not only traverse all of the things you're traversing, but then also deal with life-limiting goals of care, things along that line. But we're here to support, and that's really what palliative services do for our large hospital system. I am an advanced certified hospice and palliative nurse. I'm also a fellow of the American Association of Nurse Practitioners as well. And finally, I have a disclosure. I am on the Salix Pharmaceutical Speakers Bureau. We won't be talking about any of their products today, so shouldn't be an issue. All right, let's talk about learning objectives. Over the next probably 45 minutes to an hour, I want to look at really the evolution of nurse practitioners. I love looking at kind of the history of how we got to where we are. So often we think we haven't come very far, but my friends, we have come really far. So let's talk through that. Then we're going to define both individual and workplace factors that influence your well-being. How do you stay resilient? How do you stay relevant? And it's really through your well-being. We have to be very pointed and very, honest with ourselves to say, we've got to do our best to keep ourselves healthy so we can continue to take care of our patients, of our staff, of all those that we are caring for. We're going to explore the importance of boundaries in the midst of a crisis. And finally, characterize ways that wellness can be fostered within yourself and your team, because I think that's vitally important. Again, I didn't talk much about it. I didn't think much about it. I have always loved being a nurse. I've always loved being a nurse practitioner. And I think for so long, I felt like that was enough, and that was going to really guide me, and that was going to keep me relevant and resilient, and there wouldn't be burnout. But you know what? We survived COVID. Oh my goodness. And that has been, I think it was the turning point of really saying we need to take care of ourselves as providers. And we're bad about doing that as nurses, aren't we? We take care of everyone else, but we oftentimes don't take care of ourselves. So let's look now at the current landscape. Where are we? Well, talking about resiliency, we have a lot of patients that need our care. 101 million patients that do not have adequate primary care access. Rural communities, access where providers are leaving, large cities even are lacking access to primary care. 165 million patients without adequate mental health services. And we know this because we see so many of us having to treat mental health within our primary care setting because we don't have access. We also know psych mental health and psych nurse practitioners are on the rise, which we're very grateful for, and they're very needed, but still we have an inadequate amount of mental health services for our patients. We have an aging population. 80.8 million are going to be 65 and older by 2040. Just think about that. 1 in 5 Americans by 2040 will be over the age of 65. We've done an amazing job by helping patients and people live longer, but oftentimes living longer can come with more health inadequacies and health disparities, and all of those things come into play. And then we want to go back up and say, well, we've got inadequate access to primary care. We've got to find a way to be able to care for our aging population. But here's what we also know. In just a few short years, and by 2026, it's estimated there will be a shortage of up to 3.2 million healthcare workers. I hear, and I'm sad a lot when I hear people say, oh, I'd never have my daughter be a nurse, or I'd never have my son go to nursing school or med school or any of those things. And I say, I love what I do every single day. Is it frustrating? Are there days that I don't love as much as others? 100%. But I would absolutely actually have a daughter that just finished nursing school. She became an RN in May. She is working this morning at the bedside. She is in the hospitals at the bedside doing the work that many of us started. That's where we started. I started on an acute care oncology unit, and that's where I worked, and that's really where I got amazing experience. And then we've all gone on to do other things, but we need nurses at the bedside. So I'm honored that my daughter has taken up the call and really is at the bedside, taking care of our patients every day. So I do encourage it. There's so many things you can do with a nursing degree. And so I really do encourage, if anybody is interested in it, I love to talk about to young people about nursing and medicine and opportunities that are out there for our population. And we need it. We have a lack of access. We have an aging population, and someone needs to take care of them. We're aging. We're not going to be here doing this for the rest of our lives. I thought for many years I would never retire. But wow, as we get older, we start thinking maybe retirement is in my future. So then who's going to take it up, and who's going to do this for us, and who's going to take care of us? Here's what's interesting. Advanced practice providers, nurse practitioners, physician assistants are among the most in-demand health professionals. And according to the US News and World Report, nurse practitioners are ranked #1 in the best healthcare jobs. What do nurse practitioners do? A lot of things. We increase access to care, and we know we have amazing outcomes. Not only that, advanced practice providers have an all-time high satisfaction and confidence rating. What do you hear the population say when they talk about seeing a nurse practitioner or a physician assistant? Usually they'll say they listened to me and they made it so I could understand what was going on with me. They broke it down into words that I understood, and they made it simple to understand what was going on with me. They aren't just a diagnosis. They aren't just an illness, but they're our patients. And we know as nurses, and I think what I love most about being a nurse practitioner is the fact that as nurses, we don't look at a diagnosis. We look at the whole patient. And the whole patient is affected by any disease, by any illness. Not only that, oftentimes they're affected, it affects their family. We as nurses have been trained to look at the whole patient. And I think that's vitally important. And I think that's where this all-time high satisfaction and confidence rating comes from. If you're on social media, or if you read certain things and propaganda, if you will, you may see something different from this. And you may see that, in fact, we're not being trusted, or, whatever. And there's not, you don't get as good of care as other providers, if you will. But my friends, do not listen. You can see U.S. News and World Reports really show that we are ranked #1, and we have this all-time high satisfaction and confidence. So don't let that information get you down, and don't believe everything you see on social media. Well, what does the state landscape look like for nurse practitioners? 27 states and DC have current full practice authority. If your state does not have current full practice authority, and I currently have license in 2 states. I practice in Mississippi as well as Tennessee. Neither of my states, unfortunately, at this moment, do not have full practice authority. We need to be pushing for full practice authority. It's vitally important. I will tell you, in the 2 states I practice in, I think Mississippi is probably closer to getting full practice authority, but Tennessee is working diligently. So all of our states really need to be working toward this. And I remember I talked about Pennsylvania and Florida. We see you guys, and we're all in the same boat, but we need to be working and pushing toward full practice authority. Let me also share this. When we achieve full practice authority, our work is not done. One, we have to keep full practice authority within our states. But also we need to continue to advocate for excellent care that we're going to provide, and the abilities to have that care for our patients. So just know we are working to full practice authority, but that work is not going to be over the day we achieve that, but it's coming. So we know that as nurse practitioners, it's either a graduate or a doctoral level education. And we know that we're pushing more toward that doctoral level of education to evaluate and diagnose patients, order, interpret diagnostic tests, initiate and manage treatment, including prescribing medications. And this is what we're doing every single day in our practices. The future of nursing 2020 to 2030. This is from the National Academies. They kind of did this large paper on really what the future of nursing should look at and should be focused on. Of course, we talk a lot about social determinants of health, health equity, and diversity in the workforce. We've heard those terms, and we know that these have been initiatives for a number of years, and they need to continue to be. Interestingly enough, the Future of Nursing 2020 to 2030, also now has mentioned your health and your well-being. We know that without your able bodies to practice, we won't be able to meet the social determinants of health needs, health equity, or diversity in the workplace. So this has been a great addition about adding in health and well-being, which we're going to focus on. And then leveraging research, education, technology, and finally removal of barriers. That goes back to this slide, removing barriers of practice. And really being allowed to practice to the full extent of our education. I want to point out here, and I know I skipped back for a moment, but I do want to point out here, did you know that in most of the states that we see that are yellow and red, they're also the states that have the lowest health outcomes and health risks. They have the high health risks state. So it might tell you that full practice authority can help us to meet rural access to care. It can help us to meet and improve health outcomes. It just makes sense. So what challenges do we encounter as nurse practitioners, external and both internal? External, of course, it's everything that is pushing for your time outside of you. Lack of positive feedback, time pressure, high demands at work. Do you remember, and some of you may not remember, we used to have that 15-minute visit. In fact, our office visits are now down to somewhere between 6 and 7 minutes. So it's 6 and 7 minutes that the patient is eye to eye with the healthcare provider, not 15 minutes. So we've literally dropped the care by half of the amount of time that the patient gets to spend with us. High demands. We do this because it is more costly to keep practices open. We need to see more patients to be able to make ends meet. All of those things are coming into play, and these are external challenges that really can lead to less resiliency, burnout, all of those things. There's absence of social support, lack of freedom to make decisions. Very often we're being, our decision making is being decided by what? Other providers? More importantly, insurance companies. We might say a patient needs a medication, and we might have to jump through many hoops to try and get that patient that medication. So we really have the lack of freedom to appropriately treat our patients. And then you see here lack of role clarity, bad atmosphere. All of those things are the external challenges you're seeing every single day. Now, internally, overestimation to deal with challenges, suppressing our own needs. That is where nurses can really do a great disservice to ourselves, suppressing our own needs. So often we think we'll take care of that patient, we'll see one more patient, we'll do one more thing. And in all reality, what we're doing is suppressing our own needs and really can cause problems. Now, perfectionism, that's a nurse if I've ever met one. Wanting to be perfect, wanting to do things with perfection, I think is appropriate, but really those internal dialogue of perfectionism and of never truly reaching that. We can't be perfect, right? High self-expectations. Again, this is a nurse. We have high self-expectation, and I think we should, but we cannot set the bar so high that we're not able to meet it. A strong need for recognition, always wanting to please others and feeling irreplaceable. If I don't do it, if I'm not here, it won't get done. Those are things that we really have to work on. And these are challenges that we every day encounter as nurse practitioners. So it's things to be mindful of that are coming against you both externally and internally. So how did we get here? Well, now this slide says vaccines may be on the way. Mind you, this was 2020. This was actually from the New York Times, but a parallel pandemic hit us as healthcare workers. Not only the trauma of the pandemic and of COVID, and I don't want to just focus our time there, but we have to agree that COVID was a turning point for many of us. And it really brought the idea of this trauma and of our resiliency to the forefront of how it affected us. So this says vaccines may be on the way, but many of our front lines are burned out. Has the government done enough to alleviate their stress? So again, we had trauma of the pandemic, but then we had true exhaustion. What happened in the beginning of the pandemic? We were all applauded. People would come stand outside the hospitals and clap when we walked out. They would bring signs, they would bring food. We got all of those things. And then we settled into the pandemic, and then the people didn't come, the food didn't come, and we were still exhausted. We were still dressing out in our full PPE. We were still seeing these patients. We were still watching these patients die many times. And there we were. So we had the trauma of a pandemic that none of us have ever lived through, but the exhaustion that we had to keep on keeping on. And so there was question of really, to what expense has this pandemic cost our healthcare workers? Think for a moment for yourself. What are 3 ways that the pandemic has impacted your well-being? And then what's worrisome? You know, again, I didn't think much about burnout. I didn't think much about fatigue prior to the pandemic, but I saw it and I felt it. And it wasn't a fatigue that I could go home and get a good night's sleep from and feel better the next day. It was an emotional fatigue that I'd never experienced. And I'll share that with you, that was really what impacted my well-being. During COVID, I was at the front lines, and the front lines in that was where palliative medicine really shined in the hospital. Shined or trudged through, maybe would be a better word. What did we do? We were in the ICUs very often. We were having the hard conversations, explaining what this looked like, explaining what the oxygen was, explaining proning, explaining how long a patient can safely be on a ventilator before we had to make other plans for that patient, explaining the outcomes. And we did it day in and day out. We had very hard conversations with families when there would be a mother and a father both in the hospital at the same time, very ill. Sometimes in this, sharing ICU rooms, they're not sharing, but next door to each other with poor outcomes. So again, we walked through, and as palliative medicine, we were on the front lines. I was absolutely honored to be on the front lines with many of you, but it was exhausting, and it has become worrisome of what the impact has been and will be. So what I want to focus on as we kind of begin to turn our attention is, how do we change the subject? How do we change how we feel about it? How do we, one, honor each other that went through it and move on? Because we're ready to move on. I think we'd all agree. So let's look at it, burnout and depression. How did we get here? Interestingly enough, looking at, and this was done in 2022. So again, post COVID, but I don't know how different this would have looked. I definitely think there was an impact, but we know there was burnout. We know there was depression prior to COVID, but here's what we found. Burnout was high in both full-time and part-time employees, interestingly enough. Depression was on the rise. Patients feeling both burned out and depressed on the rise, interestingly enough. And as you can see, it seems like it affected full-time employees the most, of course, we'd say, because you have to get up and go back every single day. But as you can see at the bottom, none of the above, there's still resiliency. So I want to target those people. What did they do differently? And what were they doing to keep themselves from becoming burned out and depressed? There's things we can do. And I think more than anything, we must be intentional to avoid this moving forward. So let's look at, what is burnout? We hear these sexy topics and terms, if you will, or just these kind of propaganda terms. Burnout is one. We've heard a lot about burnout. I think we really did understand it and live it once we made it through COVID about what it really is. Because what happens? I mean, during COVID, you're kind of just flying blind. You are working as hard as you can. You just are maintaining. But then when it begins to decrease, the numbers decrease, and we saw COVID kind of begin to go, not away, but kind of become what it was, then that's when we begin to feel exhaustion. And so burnout is physical or emotional, and I'll say and emotional exhaustion, involving a sense of reduced accomplishment, loss of personal identity. It's a syndrome conceptualized as resulting from chronic workplace stress. So what do you get? Feelings of energy depletion or exhaustion. I think we can all agree with that. On many days, we feel this. An increased mental distance from one's job, or feelings of negativism or cynicism related to one's job. And finally, a reduced professional efficacy. So what we're doing, it may feel like it no longer matters. I'll tell you it does. But honestly, we get to a point where it feels like maybe it does not matter. So this is an occupational context. And really, burnout is not experienced in other areas of life necessarily. So this is really an occupational context, if you will. So how long have NPs been burned out? Again, this Medscape study was in 2022. So you can kind of do the math, right? COVID started in 2020. If you'll look at 1 to 2 years, 42% of patients of NPs that were burned out have been feeling it since COVID began. What was happening? We were working long hours. We were working extra. We were at the bedside. Some NPs went back to the bedside to help, and we began to feel this. So you can see there was an absolute uptick of burnout around the beginning and into early COVID, and 20% more than 2 years. So even before COVID happened, many nurse practitioners were beginning to feel burned out. So you're more or less burned out than during COVID quarantine months. Interestingly enough, quarantine months were kind of interesting. While we were all still working, what happened? Everybody came home, oftentimes, not everybody, but many. We had our children at home. We had even some older, adult children kind of came back because they weren't working or they were working from home and things like that. And so honestly, burnout wasn't, and it was during this kind of interesting time that we weren't seeing as much burnout during that point. But as you can see, more or less burnout during COVID, you can see now that we have more burnout. So what happened? We have to keep working. Life went back to the way it was. Maybe everybody kind of dispersed and went back to jobs and doing their thing. A lot of things have happened over the last few years. And as you can see, people are feeling more and more burned out, which worries us because we just talked earlier about how many people are going to leave healthcare. And this could be the cause of it, or a big cause. What contributes most to an NP burnout? If you'll notice here, the top reason for burnout, too many bureaucratic tasks, charting and paperwork. The other day, I was walking back to my office, and I usually see most of my patients in the morning in the hospital. I might run back and forth in the afternoon if I need to, but I like to see them kind of all in the morning or early afternoon. And I remember walking back to my office thinking, okay, now I have about 3 hours of charting. And I thought, 3 hours worth of charting. So I've seen patients for about 4 hours maybe. And this is between, going between patients, family meetings, all this thing. And then I knew I had about 2.5 to 3 hours worth of charting. And so these bureaucratic tasks, while they are important, they are taking an exorbitant amount of our time. There's a lot of talk about how AI may change our charting. There's a talk about scribes. There's a talk about ways to help with this. But at the end of the day, these are the top reasons why NPs are burning out. Next is insufficient compensation and salary. There's a lot of conversation about that, as well as lack of respect of administrators, employers, colleagues, and staff. So we need to be all respecting each other, but thinking about how and many of us are in leadership positions. How can we respect our employees? How can we keep our employees? Because it costs money to train our employees. Therefore, how do we keep them? That's a whole nother talk. But interestingly enough, the insufficient compensation and salaries. And keep in mind, when we bill Medicare, we get 85% of what the physician gets. That in and of itself can be heart-wrenching. It can be difficult because we know that we're providing equal, if not better care in most of our patients, but yet we're getting paid 85%, and we're getting reimbursed 85%. Well, if you look at what we're getting paid, we're oftentimes getting paid half of what physicians are making, which is problematic. So we need to begin to think about ways that we can advocate and improve compensation and salary based on. So it would be one thing if we got paid 85% of Medicare, and then we got 85% of compensation. That might look a little differently, and maybe that's what we push for. But nonetheless, you can see these are ways that nurse practitioners are burning out. Too many hours at work. We know there are not enough hours in many days. And oftentimes we're salaried individuals, so we're there until the work is done. Lack of respect from patients, stress from social distancing, societal issues, all of those have again come into play. And I want to point out there that stress from social distancing, but societal issues, again, we were the heroes early on with COVID. And then suddenly, as we began to educate and a lot of people's voices were being heard on social media, we were suddenly not the we were not the experts on COVID. We were not the experts on vaccines, and it got to be a lot. It split families and things like that with what people feel is correct data that may not be right. These societal issues have really led to burnout. We're no longer seen in some instances as the expert. And in some instances, it's thought that we're actually working in cahoots with other organizations. So that can be a lot to dictate as well, and a lot to traverse through. So has NP burnout negatively affected personal relationships? I think it'd be hard to say no, it hasn't. Do you always just leave your bags at the door when you leave the hospital? No. Should we? Of course we should. I teach this within palliative medicine, that we parachute into patients' rooms, but we have to parachute back out. And when we leave that threshold, we leave that patient and whatever's going on, we really need to leave it at the door. I want to be wholly involved in my patients, but I also have to leave it at the door and move to the next patient because there's another patient always waiting for our care. And I think it's the same idea here. We have to be very cognizant of when we leave our jobs. We really need to work hard to leave our jobs there. And when we walk over that threshold of our home, that we're fully engaged at home and leaving those things there. It's easier said than done. We have to be cognizant and we have to be intentional as we do it. But I think more than anything, it's helpful when we call attention to it. So I want to call attention to it. Think about your day this week. Think about, and my last few days have been spent on the beach. I took a little bit of time away and really kind of rebounded from, so we'll talk about vacation, but I did that. But if you were in clinic this week, as you went home, was it difficult to turn off what was going on in the office? I think as we get older, maybe we're better at it. And as we gain experience and maturity, maybe we're a little bit better at it, but it's so hard to leave your patients at the door and walk in and be fully present with your family. So I challenge you to really think about what your week has looked like and maybe do something differently if it hasn't. When we ask nurse practitioners about how they deal with burnout, well, how do they deal with it? Usually talking to family members and close friends. Now, I just got done saying you need to leave the practice at the practice and you need to go home. But family and friends really do care and they want to hear oftentimes. And so, that can be a great way to deal with burnout. I will tell you a great way for me to deal with burnout is to talk to a friend or family and we talk about nothing that has to do with healthcare. So I just let them tell me about other things. And I'll share a very quick story, and this really brought this home. I have one of my best friends passed away from kidney cancer a few years ago, actually 4 years ago yesterday. And when she did, when she was going through her treatments, I would call her on the phone some mornings on my drive to work. And we would talk about whatever. And I remember one time her saying, "Thank you for not talking about cancer." And I never thought about it. I would tell her what my girls were doing. I would, fill her in with what was going on at work. She loved hearing that. She would fill me in with what her kids were doing, things along that line. And then I remember that day she said that, "Thank you for talking about me about something other than cancer." And she shared that many people would call and they would ask her how she's feeling, how the treatments were going, and things along that line, when all she wanted to do was talk about something else and feel normal. And it made her feel normal. I didn't know I was making her feel normal, but it made so much sense when she shared that. So sometimes talking with family members and close friends, it may not be about work. It may be about anything but work, but it's just great to kind of hear something different. Now, NPs dealing with burnout, sometimes they isolate. Can we say that's positive or negative? Sleeping can be positive, can be negative if it's too much. eating junk food, exercise. You can see there's positive and negative ways to deal with burnout. And I won't tell you eating junk food is always wrong. Now, we don't want to make a habit of that, but it can help us deal. But you can just see some people deal with burnout very differently. So this was an interesting saying that I heard through COVID, and I adopted it and I loved it. It's like we're standing on the edge of the ocean in the dark. And this truly was the beginning of COVID. We're waiting for the wave to hit. We have no idea how high the wave is going to be, and ultimately when it's going to hit. And so you just stood there in anticipation. And if you think about it as a physical, physiologically, cortisol levels rise. We're waiting for that kind of fight or flight. And we're waiting and we're bracing. And that has been what COVID looked like and what our last few years have looked like. So I think more than anything, we need to provide ourselves grace. And how do we provide ourselves grace? Let's talk about it. Well, let's focus a little bit on the necessities of well-being. Interestingly enough, we need to have self-compassion. And I talk a lot about providing yourself grace. Connection and community. We cannot do this alone. And by avoiding others, it's not going to be a full well-being. Now, are there people that we have to draw boundaries and we have to kind of draw lines in the sand? Absolutely. But true connection and community needs to continue. We need a growth mindset, not just about where we're going and not just about where we are, but how and where we will go and how we want to grow. We don't want to stay stagnant. If our goal is just to stay in and where we are, well, then we might not have good well-being. But we want to always consider what are our next steps and what might we want to achieve. Finding rest in the middle of things, I think, is so important, which we'll talk more about in a moment. Self-awareness. When am I feeling unwell? Boundaries, because again, we want connection, but we want healthy boundaries of saying no when appropriate. And finally, self-empowerment. These are all necessary for your well-being. So how do we approach it? Individual approaches, really building connection and being intentional. You've heard me say it. Provide yourself grace and be intentional. Self-awareness. When am I getting overwhelmed? When am I underwhelmed? When do I need to push myself? Healthy boundaries. Healthy boundaries in that take vacation when you need it. Take time when you need it. You don't have to stay at the office until midnight. You don't have to see multiple patients if you're in a bad place at that point. So setting some healthy boundary, finding rest in the middle, all of those things that we just talked about. But let's talk a minute about workplace approaches that if you are in leadership, I think it's really important that we begin to think, how do we take care of our staff? Because that's our responsibility too. It's our responsibility in administration and leadership, not only to lead, but also to care and to take care of who we are leading. So empowering leadership. So we want to empower every one of our employees to be leaders in their own right. We want to be transparent and over communicate. I love that. I love that concept because we're bad. We think we're communicating oftentimes when oftentimes our staff isn't hearing, or they might need to hear things multiple times. So the idea behind this is to over communicate and be as transparent as possible. I want our staff to know how important they are. I want to be as transparent when I'm feeling things, because oftentimes just them knowing that we're feeling overwhelmed, when we're feeling somewhat burned out, all of those things can actually be a positive thing to help lead our groups. Building community, learning the culture. Who is your employees and how can you best lead them? And I love the idea behind learning culture, because you've seen some of those that are like, what type of employee are you? And there's different colors, and there's different ways that you can do it. But I love doing learning exercises where we learn our culture and know what type of employee you have, because not everybody is you. I know that's surprising. Not everybody is you. Not everybody wants the same things, and not everything is important. Not everything is important to you or to them. as the alternate. So know that, learn your culture, know your employees. They're not all you, and they don't all adhere to the same things as you, and they don't all, move forward with that. So really knowing your culture, I think, is vitally important. Adaptive leadership, know when to transition, know how to lead, and know who you're leading. And finally, calibrating workload. One thing I did with my staff, with my nurse practitioners specifically over the last year, was I transitioned all of my nurse practitioners to 4 10-hour days. So we were Monday through Friday, 8-hour, 5 days a week. And we found that that was really causing a lot of stress and burnout. And so I went to our higher up leadership. I presented the idea of the 4 10 hours, and that has been a game changer. My nurse practitioners now get 52 extra days off a year. And when you talk about 4 10-hour days, but then you offer 52 days off extra a year, let me tell you, they jump and they love it. And I will tell you, I've seen our workload increase. I've seen their self-concept change. I've seen a lot of that with just changing their hours. And I really see that they are taking on more, and they're really doing amazing work. And I don't see that our work has changed any. If anything, it's improved. So do something like that. Maybe not that, but do something like that. We need to be intentional in the workplace. And it says, must be intentional now, no water cooler moments. Now, this is where we've been. I think we've gotten busier. So there's not as much camaraderie. There's not as much standing around talking about days, talking about your kids. And especially this goes back to a lot of our positions have gone remotely, maybe not as much in the hospital, but we've seen a lot of things go remote. So you have to be more intentional in your workplace, because we aren't just all present at all times. And so that's important. You must be intentional now. This isn't fluff. It is important that we think about well-being. And I'll be honest, I've been one of those that I just didn't think much about my well-being. I worked hard, I put my head down, but it's really important. This isn't fluff. Find your own way to lead here. We started something in our office. We meet Monday, Wednesday, Friday for our IPT meetings for all of our patients. And we started a Friday name that movie quote, and just something fun. And, some people will do it in their voices, just something to do differently to get our minds off it. It's easy to put our heads down, work really hard, and never enjoy each other. And we found that to be a way. So find your own way to lead here. Find your own way to really being intentional with well-being in your workplace. And know this, more than anything, you are doing emotionally powerful work every single day. So know that. 2 things can be negatively. You can wall it off, say don't get involved emotionally, and you're going to be fine. Or you can just keep giving and giving. Those are both negative, and they will lead to burnout every single time. But channeling, and this is what I also call parachuting, being fully present when you're in the room, and when you leave, you leave. I want to challenge you about that. Fully present. And I really do kind of make this mental note of passing over that, the door, or passing through the door of when I leave there, then I'm now moving on to the next patient, and or onto my family, and or onto my staff. But be fully present when you're in the room, but when you leave, leave. And as you know, the first 2 that we talked about, walling it off and giving, are not viable for a long term. Finding rest in the middle. Sorry, I'm moving this down. Okay. Finding rest in the middle. There's actually a book about, it's called Wintering by Catherine May. It's a great book, and it's really about when to take a break. And you can find rest in the middle of things, in the middle of your day. So it might not be that you have a week to take vacation. Maybe you do, and I advise you to do it, but maybe you don't. But be intentional about that time. Pay attention to where you can rest in the middle of the day. In the elevator, take a deep breath, dropping into my coffee, just holding your coffee, taking a minute, enjoying the taste. What does it taste like? Being intentional. And really, there's an intentional permission to winter a bit, maybe to slow down, maybe to not see as many patients, maybe to just breathe. Exercise, meditation, and vacation too. So make certain you're always pouring into yourself, always. Because if you don't, no one else will. A great book, Resilient Grieving. And this is Lucy Hone, who I'm going to speak about, and this is how we're going to end our my keynote. Lucy Hone was a PhD, and she actually did a lot of research on resiliency. Interestingly enough, to know about Lucy Hone, she explained that she lives in Australia, and she came back during a flu epidemic. And this was not many years ago, but during a flu epidemic, and they were having a lot of illness and things along that line. She thought that was kind of her grieving time, and a lot going on in healthcare and things like that in Australia. What she didn't know was that really wasn't when she would grieve, and that wasn't where resiliency was going to come into play as much as she thought it was going to be needed. But in fact, they were going on a family trip. They were vacationing. Her daughter got into the car with one of her best friends and the mother, and they were killed in a car accident as they were traveling to vacation. She said that was grieving, and that's where she had to find resiliency. And it was during that time that she wrote her PhD dissertation about resilient grieving. And sounds terrible and sad, but she really made some realizations about resilience. Now, what is resilience? It's the ability to withstand or recover quickly from difficult conditions. Some things to know, and just some sayings that I love. Life doesn't get easier or more forgiving. We get stronger and more resilient. So if you notice, it's years, it's maturity, all of those things come with our resiliency. Have you ever seen older people and something, maybe you go through the same experience, but you notice it just doesn't shake them like it shakes younger people? And you might even say, in my age now, you're 20 and 30 somethings. What happens to us doesn't shake us near like it shakes somebody younger. It's that intentionalness, it's that maturity, and it makes us stronger. It doesn't get easier, but it makes us stronger. It makes us more resilient. Resilience is about overcoming the unexpected. The goal of the resilience isn't to just survive, but to thrive. I love that one. So let's look at the full circle of resiliency. We want to think about a few things. Mindful awareness, self-care, professional care, and finally, community. And this is how we prevent really burnout from it. Reflection on your values, seeking self-care, professional care. Thankfully, seeing a counselor, talking with a counselor, that has become commonplace now, and I'm grateful. It is not something that is taboo. It is not something that is not talked about. It's actually talked about a lot, and I'm grateful that we can now talk about it. And finally, mobilizing resources both inside and outside of healthcare. So perspective of Lucy Hone, she said, know this, suffering is a part of life. Carefully choose where you're directing your attention. Where should you direct attention? So I think that's vitally important to stop and think about. Should your attention be with your office? Should it be with your practice? Carefully choose where you're directing attention. Should it be when you're at the office, you're directing that attention, and then when you're home, you're directing it? But carefully choose where you're directing your attention. The other part of this is you can definitely spiral from this. Do you ever think of something, or you can begin to think of an issue or a problem, and especially we ladies, not that we're all ladies on here, but we ladies oftentimes can overthink. I've seen a lot of memes and things that were like, thank you very much. I spent all night last night overthinking for you, like to your children. But carefully choose where you're directing your attention. If we allow ourselves to overthink and continue to dwell on things, then that's oftentimes where we go. So I think you need to carefully choose where you're directing your attention. Is it positive or is it negative? Is it helping you or is it harming you? And here it is. Ask yourself, is this action or thought helping me or harming me? And one thing Lucy said was, Late at night, she would oftentimes pull out pictures of her daughter, and she could just look through picture after picture after picture. And she had to finally stop herself and say, is this action actually helping me, or is it harming me? And she discovered during that time that it is harming and was harming her. And so she began to think about, what am I going to do during the night? Giving herself different things to do to where she didn't just fall back into that. There's some interesting psychiatric thoughts about that, and not psychiatric, but psychosocially and psychologically that go along with that, which is called neuroplasticity. And it means the more that you do anything, whether it's positive, whether it's helping you or harming you, the more you do it, the easier it is for your brain to go there and do that action. So, we say when you have a habit, you need to do something for 21 days. So make your bed for 21 days, and then it becomes just a part of you and it becomes the habit, right? Because you're programming your body and your mind to do it. Same idea with negative things. If you continually think negative thoughts or, things that aren't helping you or that are in fact harming you, you can easily do it. And so oftentimes if you meet people that are constantly negative, it can be from this concept of neuroplasticity, because it's easy for them to do that. It's easy for them to turn that part on in their brain. So I want you to think, are certain actions or thoughts helping me or harming me when you're thinking about resilience and thinking through grieving even? We've all been there. We all go through grief. And then finally, where do you find joy? So I want to challenge you and think for a moment, where do you find your joy? And I'll share my joy with you. We have had a sweet addition, and that is our grandson, Easton, who's not pictured here, but we have a sweet little boy now who has become a part of our family, and we definitely find our joy with him. But dogs, our land, our family, those are our two girls, and the boys that they brought into our family. So now we have boys as well. But I want you to think about, and this is just my joy, but I want you to stop and think about where you find your joy. And finally, success is not final. Failure is not fatal. It is the courage to continue that counts. We need to keep putting one foot in front of the other. So I challenge you to do that. Put one foot in front of the other. You've got this. And I want you to think and be intentional to provide yourself grace and to provide yourself that next step. So always think forward. And I hope this was a positive hour that we could talk just a little bit, because I want to thank you from the bottom of my heart for what you're doing and where you're doing it. You are making a difference for every single patient and healthcare in the nation. So just in a summary, we know there's a shortage of 3.2 healthcare workers by 2026. So let's recruit, let's move the bar, let's really invest into our nurses and our nurse practitioners. NPs and PAs are the most in demand. And state level nurse practitioner scope of practice is vitally important. It's a challenge in many states, but 27 states and DC now allow full practice authority, and we need to push all the other states to come alongside and be in parity. Burnout is real. We know high rates of burnout among NPs have occurred and continue since COVID-19, but but it's vitally important to know that you're resilient and we can work through this. And there's ways to think about health coping strategies, cultivating resilience, self-care, building connection, and consider professional care as well. It's all there available for us. All right. So thank you so much for the first hour. Who is the author of the Resilient book? By the 10th hour, I'm reading some things. So one person asked who the author is of the Resilient book. I'll tell you that in just one moment. And somebody said, by the 10th hour, I'm quite exhausted. One may do an extra 2 hours to catch up on documentation. 14 hours sounds difficult. What's the accuracy and error data like over the last 4 hours? Great information. That would be interesting to know. thankfully, I've been able to work it out that my NPs work 10 hours. So at the end of their 10 hours, they aren't having to do 2 more hours of documentation, but we know it occurs. And yes, take care of yourself. 4 10-hour days can be great, but maybe not always. So it's whatever works for you and your staff. And then let me go back to that resiliency slide just so you can see it. Resilient Grieving is Lucy Hone, PhD, and the other book is Wintering, The Power of Rest and Retreat in Difficult Times by Catherine May. All right. So again, thank you so much for what you do. And let's jump into the post-test polling questions. What's the estimated shortage of U.S. healthcare workers expected by 2026? Up to 2.5 million, up to 3.2 million, up to 4.1 million, or up to 4.7 million? Very good. Yes. 81% post evaluation, up to 3.2 million. Very good. Next question. How many states in the United States have full practice authority for nurse practitioners? 19 in DC, 27 in DC, 33 in DC, or all 50 in DC? Very good. 89% said 27 in DC. That is correct. Next question. The results of a 2022 survey indicate that the current level of burnout compared to that during the COVID-19 quarantine among majority of MPs was lower, similar, or higher? Absolutely, it's higher. And we have seen that time and time again. So it has grown, it is higher. Next question. The Veterans Affairs Circle of Resilience includes self-care, seeking professional care, and which of the following? Calibrating the workload, adopting a growth mindset, setting healthy boundaries, or reflecting on values? Setting healthy boundaries, absolutely. So we need to set some healthy boundaries. So I challenge you this week to provide yourself grace, set some boundaries, and take a moment just to breathe. I think we can do it. So thank you so much for your time and attention. I always place my email address here, so please don't hesitate to reach out if you have any comments or questions. And I would love to partner with you. I'm always loving partnering with other nurse practitioners. And you can find me on all social media, so I'm available. But nonetheless, let's move forward. Let's see. There's Dr. Kingman. How are you, Dr. Martha?
I'm good. How are you?
I'm good. So you guys are in for a treat. Dr. Martha Kingman is a family nurse practitioner with the Pulmonary Hypertension Clinic, University of Texas Southwestern Medical Center. She earned a doctorate in nursing practice from Texas Christian University in 2011. She serves on various pulmonary hypertension advisory boards and steering committees, spoken at local, national, and international conferences, and is a sub-investigator in several ongoing pulmonary hypertension clinical trials. She's an active member of the PH professional network and is a past chair of the Symposium Planning Committee. Martha has co-authored numerous pulmonary hypertension publications and served on the editorial board of Advances in Pulmonary Hypertension Journal. Her main area of interest involves the management of prostacyclin therapies. I'm pretty certain that Dr. Kingman is a pulmonary hypertension expert, and I'm excited to hear from you. Thank you so much, Martha.
Oh, thank you for having me.
Yes.
Okay, let's see. All right, so we're switching gears. I'm going to talk about a disease called pulmonary arterial hypertension. Sorry, having trouble getting my slides to
I want you
advance.
to hit start presenting real quick up top
Oh, I did that one. Sorry. Okay.
and click on slide 2 there.
No,
Okay. I can move the slides for you. Oh, you got it.
I think I got it now. Sorry about that, folks. These are my disclosures. And these are our learning objectives. We're going to talk about the signs, symptoms, and some risk factors for this disease of pulmonary arterial hypertension. You may hear me say PAH for short. We'll talk about patients who would benefit from early referral to a pulmonary hypertension expert center. And then we'll talk a little bit about treatment plans as well as some emerging therapies that are on the horizon that are quite exciting, actually. So let's move and talk forward and talk about the definition and the disease toll of this disease of pulmonary arterial hypertension. This is a very rare disease when we were talking about PAH, just affects 1% of the global population, and the incidence is only 500 to 1,000 new cases annually in the United States. In the idiopathic form, which of course means we don't know what's causing it, accounts for 50 to 60% of all the PAH patients. This disease is much more common in women than men, 3 to 5 times more common, in fact. And the age of onset is between the age of 30 and 60. It has gotten older over this last decade or two. We used to think it was a disease of young women, but now we're seeing older patients. And it occurs in all genders, ages, races, ethnicities, even newborn infants can have pulmonary hypertension. Pulmonary arterial hypertension, or any form of pulmonary hypertension, is diagnosed by doing a right heart catheterization. So the definition becomes a hemodynamic definition. And if you look at the box on the left, that's the definition of pulmonary arterial hypertension that we used from the 1970s up until 2018, 2019. And that was that on right heart cath, we used to say your mean pulmonary artery pressure had to be at least 25 millimeters mercury or higher, and then you had pulmonary hypertension. In order to have PAH, you had to have normal left-sided filling pressure, which is the pulmonary artery wedge pressure of less than or equal to 15, and then a pulmonary vascular resistance greater than 3 Wood units. So if you had those 3 things, you had pulmonary arterial hypertension. Now, more recently, this mean pulmonary artery pressure has been lowered to 20 from 25. They felt like looking at healthy volunteers, actually, a normal mean pulmonary artery pressure is around 17, plus or minus 3 standard deviations, and they came up with 20. And they also lowered the pulmonary vascular resistance to greater than 2 Wood units and kept the pulmonary artery wedge pressure less than or equal to 15 the same. So we are now diagnosing a few more patients because we've lowered this mean pulmonary artery pressure. On the left is a depiction of what a pulmonary artery with PAH looks like. And what happens in this disease is that the blood vessel wall, the intimal and smooth muscle layer start to thicken. And then, of course, you have narrowed lumens in these pulmonary arteries, which is shown there in the middle. And what happens then is the right ventricle has to pump harder and harder through these narrowed pulmonary arteries. And because it's a muscle, it starts to hypertrophy, enlarge. And then over time, patients develop right heart failure and then ultimately usually die from right heart failure. If you are familiar with echocardiograms, this picture on the left is a static view of a normal echocardiogram. And for those of you who may not be familiar, echocardiograms are upside down and backwards. So on the top left is the right ventricle, which you can see is smaller than the left ventricle that it's adjacent to. And what happens in pulmonary arterial hypertension is that right ventricle gets so enlarged, which you can see on the right, that sometimes that septum between the right ventricle and the left actually bows over into the left ventricle and can kind of compress it at the end stages. But you also can tell here on this PAH echo that the right atrium is also very enlarged. Now, it's really important to spend a few minutes on this slide because the term pulmonary hypertension can mean a lot of things and is often confused by many practitioners. So I want to spend some time focusing on this. The term pulmonary hypertension you see in the box at the top is an umbrella term. Underneath it, we have 5 different types of pulmonary hypertension, and we call those groups. So group 1, 2, 3, 4, and 5. We used to call them WHO groups, so you might see that, but the World Health Organization hasn't been involved in some time now. So we're starting to just call them groups. So on the left, far left, group 1 is pulmonary arterial hypertension. That's the focus of our presentation today, our discussion today. And you can see there that it's subdivided, idiopathic, and then some other associated conditions that can cause it. PAH, again, very rare. Group 2 pulmonary hypertension is very common, and that occurs in patients who have left heart disease. That can be systolic dysfunction, diastolic dysfunction, valvular heart disease. Anything that raises the pressure on the left side of the heart can cause what we call group 2 pulmonary hypertension. The pulmonary artery wedge pressure, remember, has to be less than or equal to 15. If you have PAH in group 2 patients on right heart cath, their pulmonary artery wedge pressure will be high. That's their left-sided filling pressure. And then group 3 pulmonary hypertension is a form of pulmonary hypertension that occurs due to hypoxic lung disease. These are generally patients who have advanced COPD or advanced interstitial lung disease. They're hypoxic. Hypoxia causes vasoconstriction, the pulmonary arteries, and the pressure goes up. So that's group 3. Group 4 pulmonary hypertension, also a very rare form of pulmonary hypertension, and it's called chronic thromboembolic pulmonary hypertension, or CTEPH. And that occurs in patients who have had pulmonary emboli that have not resolved, that have become chronic. So rather than narrowed pulmonary arteries raising the pressure, these are pulmonary arteries that are blocked by blood clots. Many of those patients are surgical candidates where we can go and do a procedure and remove the clots, and then they can be cured. Group 5 pulmonary hypertension is where we put different conditions that we know cause pulmonary hypertension, but that haven't been well studied and there are no treatment guidelines for. Some examples there, sickle cell disease can cause pulmonary hypertension. We don't really have any guidelines for that, so they're in group 5 for now. Sarcoidosis also falls into group 5, end-stage renal disease, those things. Okay, so if we'll focus back on WHO group 1, PAH, what we're talking about, these are the subcategories. The first one is 1.1 idiopathic, again, makes up about half the cases. We don't know what's caused it, do a thorough workup trying to find a cause and don't find one. Then below that is 1.2, which is heritable, and that's accounts for about 6% of the total group 1 patients. Usually it's a mutation of the BMPR2 gene, and when you see it in multiple family members. 1.3 is associated with drugs and toxins. And when I started working in pulmonary hypertension was in 2000, and we were inundated with patients who took the drug fen-phen, which was a diet drug taken off the market in 1996 because it caused pulmonary arterial hypertension, and it also caused valvular heart disease. So we had a lot of these fen-phen patients for several years, and now what we see an explosion of is methamphetamine use. Methamphetamine can cause PAH, and that is our fastest growing group of PAH patients. Now, the next group subcategory is 1.4, and it's the associated with, and that includes connective tissue diseases and especially scleroderma. So patients who have scleroderma are at risk for developing PAH, have a 33% risk of developing this disease. Also, the lupus, mixed connective tissue disease, Sjogren's are also included here. HIV can cause pulmonary arterial hypertension. Portal hypertension, these are patients that have cirrhosis and develop what we call portal pulmonary hypertension. And generally, our goal is to treat them, get their pressures lower so that they can get their liver transplanted. And then the next category there under associated is congenital heart disease. These are usually patients who have simple shunts, ASDs or FESDs that were not repaired, and they go on to develop pulmonary arterial hypertension. And then the last one there is schistosomiasis, which is a parasitic infection that occurs in Asia, Africa, Brazil. I've only seen it once in all these years I've been doing pulmonary hypertension, because this is not endemic in the United States. This patient that we had been in Asia and then came back to the US. And then 1.5 is pulmonary veno-occlusive disease, very rare condition. We're not going to get into that today. And then persistent pulmonary hypertension of the newborn. Now, the prognosis of pulmonary arterial hypertension, unfortunately, remains poor. In the 1980s, there was a database that the National Institute of Health kept, and this was before there was any treatment for PAH, and the survival was 2.8 years. So we know if a patient goes untreated, that their average survival is very poor. Today, with the many treatments that we have for PAH, the survival is about 70% alive at 5 years. So still not great. I've seen some statistics saying up to 7 years is our average survival now, but somewhere between 5 and 7 years. So we still have a long way to go. Our medical therapy includes, as we're going to talk about, these pulmonary arterial hypertension specific drugs. Sometimes we use calcium channel blockers. That's pretty rare. And then when medical therapy fails, we refer patients for lung transplantation. The nurse practitioner, like I am, has a big role in the care of these patients. We are the link to the patient's family, the other healthcare providers, the patient's primary care doctor. Do a lot of ordering and coordinating and evaluating diagnostic testing, starting treatments, doing titrations. We'll talk about some of our medications are pretty difficult to titrate because of side effects. We monitor those side effects and help treat them. Adherence can be a problem in our patients due to side effects, and some of our medications are dosed multiple times a day or continuous IV infusions. So lots of work for the nurse practitioner to do in this field. So we're going to go through a case study. This is Rachel. She's an African-American 32-year-old female who presents with progressive shortness of breath over the last 4 months. She describes breathlessness, lightheadedness when she climbs up the stairs, unusual fatigue during the day, really tired all the time. She doesn't have any chest pain, syncope, or palpitations, and she was diagnosed with scleroderma 9 months ago. So the first question, other than the presence of dyspnea and breathlessness, what is the biggest clue that Rachel might have PAH? Duration of the dyspnea, being female, the right age group, experiencing unusual fatigue, or the fact that she has scleroderma. I'll give you guys a minute to respond. Okay, 83% said the presence of scleroderma. Great. All right. So all those clues would raise an index of suspicion for pulmonary hypertension, but as the majority of you said, having scleroderma would be the biggest red flag. If you have a patient sitting in front of you that has scleroderma and they're short of breath, you really should be thinking about pulmonary hypertension. Scleroderma is also more common in African-American women. Duration of dyspnea, cardinal symptom, but not definitive. This is usually a slowly progressive disease, although occasionally you will see a rapid progression, but generally it's an insidious onset of just tired, a little short of breath. Time goes by and they continue to get more and more short of breath. And this patient is in the right age group and right gender for this. And fatigue is the second most common symptom of pulmonary hypertension after shortness of breath. But certainly can be a symptom of many, many things. All right, question number 2. According to the REVEAL registry, and that's a registry of pulmonary hypertension patients in the United States, how long does it take on average for a patient to receive an accurate diagnosis of PAH? 9 months, 18 months, 24 months, or 34 months. Okay, 18 months was the most common answer here, followed by 24 months. All right. Actually, the answer is 34 months to diagnosis is the average. And that's from a registry of 3,000 people. And unfortunately, most patients finally get diagnosed, but they're already in the more advanced stages of the disease. And that's because this disease is pretty vague. A lot of things can cause shortness of breath and fatigue. And most doctors don't think of this rare disease of pulmonary arterial hypertension as one of the first things. So they'll go to 2 or 3 providers before somebody finally does an echocardiogram that appears abnormal, and then they get on the right track. So we're going to move forward and talk about how we diagnose this disease. The symptoms of pulmonary hypertension, as I mentioned, shortness of breath on exertion, by far the most common, fatigue. Many patients feel short of breath or lightheaded when they bend over. They tie their shoes or bend over for something. They feel lightheaded and short of breath. Many have palpitations. Hemoptysis we see sometimes, but it's actually pretty rare. And then this exercise-induced abdominal pain and nausea, I have very rarely seen that, but it did show up in the REVEAL database. And then weight gain. These patients develop right heart failure over time, which causes them to retain fluids. So we do see a lot of lower extremity edema. And syncope is a late sign. If we have a patient who's having syncopal events, that's a big red flag for us. The patient's in trouble, and we need to be doing everything we possibly can to get their pulmonary hypertension under control. Then they list some rare symptoms there, exertional chest pain. We actually see that quite a bit. Hoarseness is pretty rare. I think in 24 years, I've seen it 3 or 4 times, but what happens is a pulmonary artery gets so enlarged that it compresses this laryngeal nerve and makes them hoarse. We call it Ortner's syndrome. And then other things listed there are pretty uncommon, actually. Okay, so I talked to you about the classification of pulmonary hypertension when we talked about the 5 groups. This is another classification that we use, and it's a functional classification. And basically, this is a description of how short of breath the patient is. And if any of you are familiar with the heart failure approach, it's the same one. It's 1 through 4, where a functional class 1 patient really has no symptoms. So we don't have any of those patients because they haven't presented themselves to a doctor. So we don't really have any functional class 1 patients, but functional class 2 patients can do their normal activities. They can climb a flight of stairs. Climbing the second flight or exercising makes them short of breath. Functional class 3 patients are short of breath with all their activities. 1 flight of stairs, doing just about any activity will make them short of breath. Functional class 4 patients are our sickest patients. They have evidence of right heart failure. They've got lower extremity edema. They may be short of breath at rest. If they're having syncopal events, they're automatically considered functional class 4. In 2022, last year, the European Society of Cardiology, European Respiratory Society updated the diagnostic algorithm. In the United States, we do follow the European guidelines until this World Symposium that meets every 5 years meets, and then they update the guidelines for the whole world. But these are the most recent guidelines, and this is what everyone follows. And the diagnostic algorithm has changed. It's this 3-step approach. And it begins with the primary care doctor having a suspicion. And if they suspect pulmonary hypertension strongly, they refer directly to the pulmonary hypertension center, especially if that echocardiogram has significant signs of pulmonary hypertension, what we call intermediate or high probability echocardiogram. And we're hoping that this simplified approach will result in an earlier diagnosis. And this is what the algorithm looks like. At the top, you see it starts with a general practitioner who does a good history and physical, might do an NT-proBNP, that can be helpful. And then they break it down into whether that primary care doctor, whichever practitioner is seeing this patient, thinks it may be a lung disease, or if they think it may be pulmonary hypertension or cardiac disease. So on the left, if they think it may be a lung disease, they'll do some lung assessments, pulmonary function testing, maybe a high-res CT scan of the chest, those sorts of things. Did they identify a cause? Yes, great, treat that. If not, consider a further workup. And if you look at the right side where PH or cardiac disease is suspected, under that is an echocardiogram, and that's really what's key, and it's almost always the first sign or the first indication that you may be dealing with pulmonary hypertension. And then if the probability on echo is high or intermediate for having PH, the patient needs to be referred to a pulmonary hypertension center. And what I mean by that is if the right ventricle is enlarged, or they have right ventricular dysfunction, those are very big indicators for pulmonary hypertension, and that patient should be referred. So once I get to the pulmonary hypertension center, like where I work, we do a lot of things. We will diagnose the patient by right heart catheterization. We often get palliative care involved early, especially if they're already in an advanced state. We do multidisciplinary team meetings at our program. We meet weekly with all the nurse practitioners, PAs, physicians, and talk about difficult cases and get everybody's involvement. There's patient advocacy and empowerment. We have we have a Dallas and Fort Worth patient support group, which is really beneficial for patients. We do a lot of research and try to get patients in clinical trials when we can. So a lot of things going on in the Pulmonary Hypertension Center. So the patients being worked up for pulmonary hypertension, we do a lot of blood work, and we do the ANA and the ENA panel, ANCA, double-strand DNA, all these things looking to see if the patient may have a connective tissue disease or an autoimmune disease. We also check, not listed here, is HIV, and we do hepatology serologies too to see if the patient may have developed some liver disease. And then toxicology screen is listed there. We do that on all newly diagnosed patients to see if they may be using methamphetamine. And then imaging tests list a VQ scan and a CT of the pulmonary artery. We don't really do that, but we do. VQ scans are at gold standard for every patient who is felt to have pulmonary hypertension, because that's what can identify CTEPH patients, the chronic thromboembolic disease patients. In the last few years, we've started evaluating patients doing what we call formal risk assessment. And there are several different risk assessment tools. The one I'm showing you here is from REVEAL, the US registry. And it's had several iterations. First there was a REVEAL, and then there was a REVEAL 2.0. And then we got most recently this easier calculator on the right called the REVEAL Lite 2.0, which is an abridged version of the longer one. And what these risk calculators do is they predict whether patients are at low, intermediate, or high risk for death within the next 12 months. And the REVEAL Lite 2.0, which is pretty standard, most programs are using it, has 6 variables. It includes their functional class, systolic blood pressure and heart rate have been associated with prognosis, the 6-minute walk distance, the NT-proBNP levels, and whether or not they have renal insufficiency. In this large database, all those things correlated with patients' prognosis. And that's the REVEAL approach. In Europe, they have this ERS-ESC 3-strata risk assessment tool. And this looks very busy, so not to worry, I'm going to go through this pretty quick, but you can see this green column is low risk. That's where we want to get everybody. The intermediate column, the orange is, they're not really at goal. And then the high risk on the right equates to a high risk of death greater than 10% in the next 12 months. So if you look over to the left, the determinants of prognosis column, we go through each of these and look to see where they fall. For example, WHO functional class. If they're 3, they get a check mark in the intermediate. If their NT-proBNP level is 200, then they would get a check mark in the low risk. So you go through all of these and see where the patient falls. And our goal is to get everybody to low risk status because they have the best survival. That's the initial, this 3 strata that I just showed you is for the time of diagnosis. And then at follow-up, Europe recommends this 4-strata model. And what they did is they split the intermediate group into intermediate low and intermediate high. And that's because 70% of patients were falling in intermediate. And there were very different patients there. Some were just almost to low risk, and then some were almost to high risk. So they split it, and that's been really helpful. So now we have low risk, low intermediate, or high intermediate, and high risk. And so you can see on the left, at follow-up, you only have to look at these functional, WHO functional class, walk distance, NT-proBNP. So that's made it easier. The European guidelines also recommended how often testing should be done in monitoring these patients. Functional class assessment is done at every visit. It's easy. We just talk to the patients about their symptoms. That's an easy one. EKGs, we don't often do those very frequently, usually just at the time of diagnosis in our program. 6-minute walk tests are every 3 months or every visit. Cardiopulmonary exercise testing varies. Some programs do them, some don't. We don't at our program unless we're trying to figure out why the patient's short of breath and they don't have pulmonary hypertension. Echocardiograms, certainly at baseline, then every 6 to 12 months. Usually we repeat it after 3 months of therapy change. Basic labs are every 3 months. Extended labs, by that they mean the NT-proBNP at baseline, and then every 6 or 12 months. We do ours every 3 months, actually. And then the right heart cath at the time of diagnosis, every 6 to 12 months, and so on. We used to routinely do a right heart cath every year, but now if we've got patients at low risk status, they're doing well, we'll kind of hold off and spread that out a little bit. So the risk assessments tools, I talked about the ERS-ESC approach and the REVEAL approach. There are many others, but they all contain the things that are listed here. They'll all have some biochemical measure, NT-proBNP or BNP. They'll all have some measure of clinical assessment, whether that's functional class or progression of symptoms. They'll all have some form of exercise test in 6-minute walk or the CPAP. And then they all have some echo findings. What correlates with survival is actually the size of the right atrium and whether or not they have a pericardial effusion. And then hemodynamics, what correlates with prognosis is cardiac index, right atrial pressure, and mixed venous sat. Okay, so we'll move on and start talking about treatments. And these are our goals of therapy. We want to improve hemodynamics, the right heart cath findings, of course. Patients don't really care about that, obviously. We want, and so do the patients, less symptoms, overall feeling better, better exercise capacity, able to walk further on the 6-minute walk test. We try to get everybody to functional class 2. That would be our goal, and really hope that we're improving patients' quality of life and prevent clinical worsening, prevent them from going in the hospital. When patients get hospitalized, that worsens their prognosis. And then hopefully we're improving survival as well. So again, our overall treatment goal is to get patients to low risk status. We want good right ventricular function. We really put a lot of priority on how big the RV is and how well it's pumping. This is a table showing the medications that are approved by the FDA to treat pulmonary arterial hypertension. They fall into 3 classes. The ERAs, those are endothelin receptor antagonists. There's 3 of them, ambrisentan, bosentan, and macitentan. They're oral therapies. Common adverse events in this group, lower extremity edema seems to be the biggest one that we face. Oftentimes, we'll have to increase their diuretics when we put a patient on an ERA. Bosentan, the first one that was approved, has a black box warning for liver injury. So if you're using that drug, the patient has to have monthly liver function testing. And the next one listed there is a soluble guanylate cyclase stimulator, which there's one, it's riociguat or Adempas. The main issue we see with this drug is hypotension. We start at a low dose and they increase every 2 weeks based on their blood pressure. We generally put this in the same category as the PDE5 inhibitors listed below, and we call it the nitric oxide pathway. But the PDE5 inhibitors include sildenafil and tadalafil, which, as I'm sure many of you or all of you know, those are most commonly used for erectile dysfunction. But they dilate pulmonary arteries, so they're vasodilators, and we use those primarily orally. IV's listed here, but that's very rare. It's usually, these are given orally. And then we have the prostacyclin pathway. That's the most potent drugs that we have are the prostacyclins. You can see a number of them listed here in this first row. Flolan was the first drug that we had in 1995. It's epoprostenol. We now have a newer formulation called Veletri, which is also epoprostenol, but stable at room temperature. So not many people use Flolan anymore because it had required patients to have ice packs on their infusion pump. That was pretty difficult. Ventavis iloprost is being phased out. It's an inhaled prostacyclin. Treprostinil is a form of prostacyclin that can be delivered in numerous ways. There's an oral formulation called Orenitram, and then the continuous IV infusion is Remodulin, or it can be given continuous subcutaneous infusion. And then it can also be given inhaled, which is Tyvaso, or if it's done with a generic drug, it's Yutrepia. And the prostacyclins, unfortunately, have a pretty difficult side effect profile. Patients can have different types of pain, jaw pain, leg pain. They can have GI side effects, nausea, vomiting, diarrhea, loss of appetite, so on. The bottom row is PRA, that's prostacyclin receptor agonist. And there's one, it's a pill called Selexipag. And it is given orally. It also says IV there. That's in the hospital under rare circumstances. But generally, it's an oral tablet. It's increased weekly, depending on how the patient is tolerating the side effects, which are the same. Prostacyclin side effects are the same, no matter what route you're using. They tend to be less severe in the inhaled, followed by oral, and then the IV and sub-Q treatments have the most severe side effects. So most of our agents were approved by the FDA in the early 2000s. So I got to see all of these come to market. It was a very busy time, and we have now 14, went from 1 to 14 drugs that are approved by the FDA. Treprostinil is most recently been approved in a DPI dry powder inhaler versus a nebulized form. So that's been helpful for patients, a little bit easier for them to use. And there's some benefits and some drawbacks to these inhaled prostacyclin therapies. The advantage is that we get the drug right into the lungs where we want it to be. We don't have the systemic side effects to the degree that we do with other formulations. And it's rapidly absorbed, gets into the bloodstream quickly. The disadvantages is that it's an irritant to the airways. Many patients will cough after they do the treatment. And these inhaled treprostinil is dosed 4 times a day. So that can be difficult too. The patients will do their treatment, cough for a little while, and then usually be okay after that. These are the just a summary overall look at the 3 pathways that we have to treat pulmonary hypertension, which we've just talked about a little bit. On the left is the nitric oxide pathway, powerful vasodilators. That includes the PDE5 inhibitors and the soluble guanylate cyclase stimulator. And in the middle is the endothelin pathway. These drugs block the effect of endothelin, and endothelin is a vasoconstrictor and also causes fibrosis of the pulmonary arteries. So we block endothelin with these drugs. And then on the right, as we were just talking about, our prostacyclins being our most potent treatments. And we only will choose one drug from each pathway. And when I first started in pulmonary hypertension, we used to start one drug and then we would wait around and see if they got worse, and we'd add the second, and then we'd wait around and see if they got worse, and we add the third. But now we are using medications in combination at the time of diagnosis. So almost all patients at the time of diagnosis are started on an ERA and a PDE5 inhibitor. Very rarely, if we have someone who may have mixed group 1 and 2 pulmonary hypertension, some other lung disease issues. We might start with one and monitor them closely and add the second. But as a general rule, patients are started on 2 drugs up front, and that's because of the findings in the AMBITION study, which studied patients that were placed on 1 drug at the time of diagnosis versus 2, and the patients that were on 2 drugs did much better over time. And this is what they showed. This was looking at ambrisentan and tadalafil given at the time of diagnosis, an ERA and a PDE5 versus monotherapy, either the ERA or the PDE5. And what they looked at is the patients who had no clinical worsening events. That's what this graph is showing you. So the group that was treated with ambrisentan and tadalafil had much fewer events. So there were more patients without a worsening event. So we learned that 2 drugs is better than 1, and that led us to think, well, maybe 3 drugs up front is better than 2. So that was the Triton study, and they looked at starting patients on 2 drugs, an ERA and a PDE5, or 3 drugs, an ERA, PDE5, and that prostacyclin receptor agonist, selexipag, that I mentioned to you. I won't spend too much time on this study because it was a negative study. I think many of us were surprised it did not meet their primary endpoint. There was a trend in the secondary endpoint, and that there seemed to be a reduction in the risk of disease progression, but that was a secondary endpoint. Their primary endpoint was not met, which was pulmonary vascular resistance on right heart cath, and their 6-minute walk test was also not met. So this was sort of surprising to us. We thought if we started 3 up front that patients would do better, but we do not have the data to support that. However, the guidelines still recommend in a patient who is diagnosed in a high-risk status, they're in right heart failure, they're really in trouble, we do start 3 drugs, but the third one being an IV or subcutaneous prostacyclin infusion. This is the updated last year European treatment algorithm, and it starts at the top at the Pulmonary Hypertension Center, where we do a right heart cath, and we do this thing called a vasoreactivity test, which tells us if the patients have the ability for the pulmonary artery to dilate quickly. That's very rare, actually, and if it does occur, they may be calcium channel blocker therapy patients. And mainly the reason we do this is because insurance companies require it, and they don't want to pay for pulmonary hypertension drugs if there's any way a patient can be treated with a calcium channel blocker. So we do that. And then there's some general measures that patients get, diuretics, for example. And then this splits into, on the left, patients without cardiopulmonary comorbidities. So it's just a pure group 1 PAH patient. They don't have any left heart disease. They don't have any interstitial lung disease, no COPD, that kind of patient. And we do that 3 strata risk assessment that I showed you, the ERS, ESC. And then we determine if the patient is low or intermediate risk. They get started on an ERA and a PDE5. If they're high risk, ERA, PDE5, and a parenteral prostacyclin infusion. And then they get regular follow-up every 3 months at least. And at the 3-month follow-up, they get the 4 risk strata model and see if they're low risk at that point. Great, we just continue whatever therapy we started them on. If they're intermediate, and they're not already on a prostacyclin therapy, we add one. Or if they're high risk, not already on IV therapy, they get started on IV or subcutaneous infusions and referred for lung transplant. Now, if you look at the right-hand column, kind of back up toward the top there, patients that have the cardiopulmonary comorbidities. So you have a patient, you think they're primarily group 1 PAH, but they got a little left heart disease, or they got some interstitial lung disease or COPD. That's the more rare situation where we would start them on monotherapy with either an ERA or a PDE5. Usually we'll use a PDE5 and then closely follow them and see how they're doing, and then consider adding the second medication. So we're going to move forward and talk about some of the emerging therapies. There's a lot of ongoing trials right now in pulmonary hypertension, and these are just a few of them listed. There's Merck's doing a study using an inhaled soluble guanylate cyclase stimulator. There's a study, the second line, called ADUE that just finished actually, and that's been approved, and that's going to be available soon. And that is a combination pill using macitentan and tadalafil together in the same pill. So hopefully that'll be a little bit easier for patients to take one pill instead of 3, because the tadalafil is a 2-pill therapy. Ralinepag is a prostacyclin receptor agonist in that same category as selexipag, but this one potentially has a longer half-life and can be dosed once a day if that ends up being a positive study. Seralutinib is being studied. It's an inhaled PDGFR antagonist. The one at the bottom, though, is the most exciting one and really has got the pulmonary hypertension community very excited. Sotatercept is a TGF-beta inhibitor. It's a subcutaneous injection every 21 days. And they have completed their phase 3 study. That the results were fantastic. They've been submitted to the FDA, and we should know in March of 2024 if it's approved. The studies listed here, Zenith, Soteria, Hyperion, and Moonbeam, are all additional studies of sotatercept, but not the primary clinical trial. This is the ADUE study that I mentioned of the trial of the fixed dose combination PDE5 and ERA. And they looked at the change in pulmonary vascular resistance, and the combination pill is represented in blue on the left. And they had a decrease of 45 dynes in their pulmonary vascular resistance compared to the macitentan alone group. And then compared with tadalafil, a 44 dyne decrease in their pulmonary vascular resistance. So good results there. Pulsar was this phase 2 study of sotatercept. They looked at pulmonary vascular resistance, which we often do in the phase 2 studies, just to get a really good indicator if it may be beneficial. They had a significant decline in their pulmonary vascular resistance in the treated group. Both treated groups, they did 2 different doses here, the 0.3 mg per kilogram or 0.7 mg per kilogram. With even better response in the 0.7 milligram per kilogram dose. So that led to Stellar, which was the phase 3 trial of sotatercept, and it's studied as an add-on therapy. So added on to monotherapy or combination therapy, PDE5 inhibitor, ERAs, and also even patients with prostacyclins were included in the trial. And the primary endpoint was the change in 6-minute walk test, which is showed in the graph here. The blue line are the patients that were treated with sotatercept versus the placebo group in gray, and that's at 24 weeks. So they also had multiple secondary endpoints that were approved, that met as well. Those results were released at ERS 2023. So they had improvement in their 6-minute walk test. The NT-proBNP improved, the functional class improved, and these improvements were maintained at a year in the open label extension study. As far as safety signals, 23% developed telangiectasias, which is a side effect or an adverse event we've never seen in any of our pH drugs before, and kind of interesting. None of those were serious. 7 patients experienced 9 clinical worsening events, including 3 deaths and 3 PAH-related hospitalization. And the timing or the mean duration of exposure was 336 days. This drug that seralutinib, which is an inhaled PDGFR antagonist, is under clinical trial evaluation currently. The 86 patients are going to be enrolled, functional class 2 and 3. Actually, I'm sorry, this one has completed, and they met their primary endpoint, which was change in pulmonary vascular resistance at 24 weeks. Most common side effect was mild or moderate cough. Again, it's an inhaled therapy. They are now enrolling in phase 3. And phase 2 trial of ralinepag has completed as well. They enrolled 61 patients, functional class 2, 3, or 4 on standard of care monotherapy or dual therapy, and then randomized to either placebo or ralinepag. And again, this is this potentially long-acting prostacyclin agonist. The primary endpoint was change in pulmonary vascular resistance over 22 weeks, and the patients that were treated with ralinepag had a 29.8% reduction over placebo and an increase in their walk distance by 36 meters. Safety signals, occurred in 13% of the patients treated with ralinepag versus 29 in the placebo group. Most common were headache, nausea, and diarrhea, which are very typical prostacyclin side effects, so nothing new there. All right, so on to the case, another case study. This is Adam. He's a 41-year-old gentleman who was diagnosed with PAH 9 months ago. And after 3 months of monotherapy with an ERA, he was switched to dual therapy with ambrisentan, an ERA, and sildenafil, a PDE5 inhibitor. Now he's showing worsening of his symptoms and is intermediate to high risk per the ERS-ESC 4-strata model. So what do the ERS-ESC guidelines say to do now? 1, refer to a PH center, switch to a different ERA, add an IV or sub-Q prostacyclin, or add an inhaled prostacyclin. Okay, 38% said add an IV or inhaled or a subcutaneous prostacyclin. And then 26% of you said to refer to a PH center. Okay, so this patient has intermediate high risk group status, and triple therapy is currently indicated by the guidelines for an intermediate high or high risk patient. And then some of the other answers refer to a PH center. It's assumed this patient's already been referred for an accurate diagnosis and treatment. Hopefully they're already at the PH center. Switch to a different ERA. That's not really something we do. One ERA is pretty much the same as the other ones. Ambrisentan causes a little more swelling, but we wouldn't change ERAs just because of clinical worsening. We would add on therapy. So add on an IV or sub-Q prostacyclin is a correct answer, as many of you noted. And then add an inhaled prostacyclin is not really included in the guidelines for a high risk. We usually use those in patients who are more low or lower intermediate risk status. Okay, the patient is asking about possibly adding sotatercept, a drug he heard about on social media, which is actually, we are hearing this all the time. What is your correct response about this treatment? 1, it's not indicated for PAH. 2, it works only as monotherapy. It's not yet FDA approved, or it's only for group 4 PH. Excellent. 54% said it's not yet approved for PAH, and that is the correct answer. It's still waiting FDA approval. Believe the date is March 28th, the last date that the FDA can give their answer. It's not indicated for PAH. That's not correct. It works only as monotherapy, also incorrect. It showed improvement in monotherapy, dual combination, even triple therapy. And not yet FDA approved is the correct answer. Only for group 4, that's incorrect. It's actually not even being studied in group 4 pulmonary hypertension. All right, so in summary, pulmonary arterial hypertension is a disease that's characterized by pulmonary artery remodeling, which eventually leads to right heart failure and death. It's usually PAH. This is usually idiopathic, but actually about half of the cases of PAH are idiopathic. It does affect all ages, genders, and races, more common in women than men. And the nurse practitioner plays an important role in the diagnostic testing, treatment initiation, treatment monitoring, lots of things that nurse practitioners do in this disease state. Multiple treatment options are now available, with more on the way. And combinations are designed to affect different molecular disease pathways. That's why we use them in combination. They'll work a little bit differently. And then treatment guidelines recommend dual therapy for almost all newly diagnosed patients. So we're going to move on to the question and answer section now. I believe Brett is going to come back on. Brett, it looks like you're muted.
There we go.
Okay.
Perfect. Thank you so much. Thank you. Thank you. All right. Let's see what we have. I was looking at questions. Well, it says, thank you for an awesome presentation. They've gotten a lot of accolades. I don't see any questions. I can't
Okay.
imagine. Yes.
Well, great.
Yeah.
Okay.
Do tell me this. And you may have, and I can't remember if you mentioned it or not. When do you get palliative medicine kind of involved with your patient? Kind of when do you recommend that to be kind of an added part of your patient's care?
Yes. What we've decided in our practice is if a patient's placed on a parenteral prostacyclin, either an IV infusion or subcutaneous infusion, at that time, we initiate a referral for palliative care. We just did that because it was an easy trigger for us to remember and make sure that we didn't, that we don't miss anybody. It really, honestly, we should probably be doing it sooner than that. They're very helpful with managing patients' symptoms and helping them with end-of-life decisions and planning and so forth.
Yeah, perfect. Yeah, because we see a lot of pulmonary hypertension patients that may have, and that's what I think is important to push home, not taking over your presentation at all, but may have years of life. So not hospice, not 6 months or less, but years of life that still symptoms can be very burdensome, but also kind of what's the line in the sand for that patient and kind of what they would want, in the event that the medicines aren't working, they're not working well. So yeah. Oh, yeah. We did get some questions.
Okay.
I have a PAH patient only on inhaled Tagrasso. She wants Teflon pearls for uses cough syrup. Oh, and uses cough syrup. What are your thoughts about cough suppressants and things along that line with your patients?
I have no problem with them.
Oh, okay.
Yeah, and anything you can do to keep the patient on therapy, in my opinion, is fine. Yes, cough suppressants are fine.
Good, and that's another question, because oftentimes when they get referred to an expert, and they get referred out, then you always think, I don't want to step on toes. I don't want to add any, unless I would want to know that Dr. Kingman said, yes, it's fine. So those are good things. So you don't have any issues with that.
No.
Good. Perfect. When does a patient become eligible for an LT? It says, I work in CVICU, and when I was a bedside RN, we had many patients on IV pH meds.
So lung transplant is indicated when patients are failing maximal medical therapy, or if they remain in intermediate high or high risk status after maximizing their therapy. And by maximizing, I mean 3 drugs, and the third one in the prostacyclin category being an infusion, subcutaneous or intravenous infusion. As a matter of fact, at least in our program, when we refer to our lung transplant colleagues, they don't want to work them up unless they have failed IV therapy or sub-Q therapy, because they want to make sure they've got full maximal medical care, that they're failing, and then look at lung transplant. Because we always want to try to avoid lung transplant as long as we can, because the survival with that is still poor at about 5 years. So we don't want to start that 5-year clock until we really need to.
And then what age is kind of a cutoff that you wouldn't consider lung transplant?
68, 70, so something like that. It depends on the transplant team looks at a lot of different variables. You can have a really young 70-year-old.
Sure.
You can have a really old 70-year-old. So it varies a little bit, but around 68, 70.
Gotcha. Good to know. What are ethics of treating a 96-year-old male with PAH?
96. It depends on the 96-year-old.
Individualized treatment.
Yeah, you have to talk to the patient and say, do you want to go down this path or not? Many of the patients that are older like that, and we do have people in their 90s that are treated for pulmonary hypertension, they choose to do it because they can relieve their shortness of breath, not completely, but improve their shortness of breath. And, there's got to be nothing worse than not being able to breathe. So they'll opt for treatment because they want to feel better.
Mm-hmm.
But
quality of life.
Right.
Yeah.
We've even put people on IV therapy in their 90s.
Yeah. I mean, I think you all individualize treatment. And there are some, like you said, there's some very frail 60-year-olds and there's some very spry 90-year-olds. So you never know, you don't want to ever say that's the cutoff.
Right. And some of the older patients will say, I'm 90. I don't need another diagnosis, another doctor. I don't want to do any of this. And you just tell them, what the future might look like without treatment. And then they are certainly, can make their own decision on that.
Yeah. And palliative medicine can help do that too.
Right.
I'm not trying to sell palliative medicine today.
I completely agree.
But they're fantastic. That can be a great time to say risk and benefit and, what their goals are and are we meeting them? And then one final question, will using TGF beta-1 blood tests in these patients ever be accepted to help determine a diagnosis?
Oh, I doubt it. I don't think for diagnostic purposes, because you really have to have a right heart cath to get. And the main reason is that if you don't have that pulmonary artery wedge pressure by right heart cath, you don't know if you have a group 1 or group 2 patient. That's how we distinguish between the two. And the group 2 patients, we don't treat with PAH drugs because it can cause harm and make them worse. So they absolutely have to have a right heart cath for diagnosis. I don't know if the future is ever going to be a blood test that will, be diagnostic. Maybe in the future, but we're certainly not there anytime soon.
We never know. That's all right.
Yeah, I may be long retired by then.
Yeah, you're right. Perfect. Well, thank you so much, Dr. Kingman. There's been questions about, will you guys get slides? And the answer is yes. You will get it post-program. So you will have those emailed to you. So those that are wanting the slides, these are emailed to you. All right. Thank you so much, Dr. Kingman.
Thank you. Bye-bye.
Yes, thank you. All right. For our participants, we are going to take about a 15-minute break. So we will come back at 11:45 for our next presentation, which will be Lee Simpson, nurse practitioner, talking about nurse practitioners on the front lines and integrating multi-cancer early detection testing. So 15 minutes and we're back at it.
I'm sorry to interrupt, but we have to do the post-test real quick here.
Oh, Connor, thank you.
That's okay. Here we go.
Okay.
Okay, this was the last question here. So yeah, we're going to take about a 10-minute break now. Thank you, everybody. We'll be right back.